circumferential prolapsing piles. So it is very difficult to answer that afterwards. So now onwards I am giving the clue to the patient in OPD that this is the possibility of diagnosis, but my confirmatory diagnosis will be under anesthesia only, and I will take, according to that diagnosis I will take a surgical decision. And these are the surgical option. If you want to go, you can give the freedom to me to use the different type of surgical step. Now the patients are definitely giving that much confident to us, please do whatever you want, but explanation is very important. And so the OPD examination of piles or perianal will be definitely a different in a peroperative after the giving the anesthesia, because of the why, because of the motor action of the patient. That means patient will be in agonizing pain, shyness, position, as well as proctoscopy diameter will not sufficient to make a definite diagnosis. Now to the proctoscopy examination. This proctoscopy examination you should take in adult larger diameter proctoscope and the smooth surface proctoscope. Many times we are using a different company proctoscope, and they are remaining in the single tray. That's why the obturator, male and female obturator, will not fit, and if you insert this proctoscope, the patient will have a bleeding and trauma. So ideally, you keep proctoscope in a larger diameter, as well as in the one company, so it will not mismatch. First, do the PR examination. Don't do the proctoscopy examination directly. Do the PR examination with the xylocaine and ask the patient to take breathe out and breathe in. During the every taking breathe out, you push slowly proctoscope inside that, and the handle must be towards the sacral cleft. So then and then the whole the proctoscope go inside. Otherwise, if you put the proctoscope towards the buttock region, then it will not go fully inside. So keep the handle towards a 6 o'clock position, so the proctoscope fully go inside, and then take a battery and examination the perianal region. As well as slowly this proctoscopy withdrawal is very important, like a colonoscopy. The withdrawal, during the withdrawal you will get a definite clue about the disease. So withdrawing, during the withdrawal, if you see the congestion bluish or the purple color mass protruding inside the proctoscope, these are the piles one, while the pinkish color, they are the mucosa one. So slowly the withdrawal till the anal verge, you will get a examination, or you will get a diagnosis of piles. One more thing I want to give, nowadays the piles, the surgery, initially it was grading one, that's a grade 1, that means that the enlargement of anal cushion, that is a grade 1. Grade 2, they are the protruding inside the piles while they're doing the proctoscopy, but they are not coming outside, that is a grade 2 piles. And grade 3 piles, they are the piles which are coming out from the anal region during the defecation process and do not need to reposition, mechanical reposition. They are the grade 3. Grade 4, they are coming out and they remain outside, and they may require a manual reposition. That is a grade 4 piles surgery. But this is for the only pile surgery. Nowadays, we are treating piles as a general disease. That means that the patient may associate with the fissure surgery, the patient is may associate with the obstructive defecation syndrome, the patient associated with the rectal mucosal prolapse. They are the different type of disease also associated. So you have to get that clue during your examination that the patient may require not only the pile surgery, may require with the explanation, may require a simultaneously prolapsing disease also. As per example, the patient having a large prolapsing piles, and if you are saying that there is a flat buttocks, that means the anal and the both the buttocks are the same level, then this patient, and the patient having female is there, and patient is having a urinary complaint and difficulty micturition or incontinence of urine, the only prior surgery will not help. Patient may require pelvic floor tugging, and so these are the all investigation is very important, the diagnostic very important. So only grading of piles is not an answer. You required a simultaneously examination. If you find on the perirectal examination a loose mucosa, roomy mucosa, and if you able to roll the mucosa with your finger, these are the rectal mucosal prolapse. So this may require tugging of mucosa or excision of mucosa in depend upon your choice of the surgery. Many times patients are coming with the pain and the prolapse. So we are always thinking the patient is associated with the fissure and prolapsing third degree piles. Normally third degree prolapsing piles will not require any sphincter surgery, because this prolapse itself make the sphincter very lax. If you are doing this sphincterotomy or something fissure related surgery, the cutting of the sphincter, there may be a chances of post-operative incontinence. So the prolapsing piles, do not consider the fissure sphincter surgery. Yes, there may be a chronic fissure. You can do the pile surgery as well as refashioning of the fissure or excision of the chronic fissure margin. There will be a sufficient one. So make a diagnosis that patient may be a second degree piles with a fissure. Yes, you may require a sphincterotomy and a pile surgery, but or the larger component of fissure is there, then do the fissure surgery. And if you do get the larger piles inside, you can go for the surgery. But the symptoms of prolapsing and mild burning pain, then don't do the sphincterotomy. Okay, so local examination, digital examination, proctoscopy examination, grading of piles, these all are various means there may be a different for me, it may be a different for my PGs, it may be a different for my AP, and it may be a different for my senior also, because it takes an expertization, it need expertization. You require a lots of examination and confirmation of diagnosis during your surgery. So like a fistula, the MRI, the Park's fistula and MRI fistula is outdated after the coming of MRI. So this way, the grading of piles after the coming of this obstructive defecation syndrome, prolapsing mucosa, as well as MIPH, star procedure, tube tape procedure, they are now only grading is for the mentioning or to understand. Okay, most important now I believe that the examination under anesthesia only. If you do the examination under anesthesia, there will be a confirmatory diagnosis of anorectal disease.